Hello, good day, and welcome to COVID-19 Simulator for Policymakers, CoSimPol. My name is Dr. Shamim Budanya from the Leadership Dialogue. So, CoSimPol is an extension of an earlier simulation done for the public. It was called CoSimPub, and the purpose of that model was to give the public a sense of the underlying dynamics around the COVID-19 epidemic. CoSimPol is designed specifically for policymakers to be able to explore different policy options in dealing with the epidemic. Again, the purpose of this webinar is to first give users an understanding of the key dynamics. The CoSimPol is designed using the system dynamics methodology, which is essentially a series of using mathematical equations of nonlinear dynamic systems. But the basic structure is outlined using what is known as stock flow maps that then is put together through using the various key relationships. CoSimPol, the user is able to calibrate it for different settings and contexts, so for different country settings, as well as different localities. It enables the user to check all of the assumptions given in the base case, and therefore to be able to change those assumptions if one disagrees with them, or if the scientific evidence shows something slightly different to what the base case is representing. This ability to change the assumptions underlying CoSimPol also enables users to mediate between different scientific positions as more knowledge about the COVID-19 gets uncovered. This is not fully understood, the epidemic is not fully understood, and there are varying different scientific positions around the spread of the virus. It also helps to critique and validate the underlying data, the assumptions, so that one gets a more robust model to be able to use for policy making. So CoSimPol begins with the same basic structure as CoSimPub, which I've covered in an earlier webinar. But CoSimPol is more sophisticated, more nuanced, has more logic built into it, and develops it further, especially in relation to the policy positions. It models R0 as well as dynamic changes of effective R over time, and it enables fully user configurable operating parameters. Some of the features of CoSimPol: it enables the user to firstly enter the number of known cases on the first day of the simulation, but also to include assumptions and proportions of unknown cases to known cases. As we know, in various country settings, the testing and tracing has not moved as far enough or fast enough, and therefore the actual cases may be far higher than the known cases, and one may make some assumptions around that and do some sensitivities around that. It enables the user to be able to define the initial hospital and critical care bed capacity, which obviously would then impact on how the epidemic spreads and capacity constraints in hospitals. It enables the modeling of building of new bed capacity. So, for example, in some countries like South Africa and elsewhere, they are building field hospitals, and that can be built relatively quickly. And CoSimPol enables the modeling of the building rate of new bed capacity. It takes into account the quality of in-hospital care, and there's a set of parameters one could use around that. So the impact of quality obviously impacts the care in hospital and impacts death rates when patients are in hospital or in critical care. It enables the user to model of up to 2 lockdowns of varying intensity, as well as non-pharmaceutical interventions such as social distancing, use of personal protective equipment, etc. And these NPI interventions are modeled with a nonlinear decay of effectiveness. The science of the epidemic is not fully known, and therefore we don't fully understand yet whether people who've had the infection and have recovered, whether they're immune or not, and the model allows the user to model full immunity or losing of immunity in various rates. It has 3 different vulnerabilities of infected patients. in terms of those that recover without hospitalization, those that recover through hospitalization without critical care, and those that are requiring critical care. One may model different values of R0 by changing the infectivity and the contact rates. And the model provides a full sheet of assumptions for the base calibration that's given, and it's shown, so that enables the user to critique those assumptions and to change those assumptions based on the data for their particular context and settings. The base case of CoSimPol, it has been calibrated now for South Africa with an R0 of 2.94. Some of the salient points in relation to that base case is that infections will peak towards the end of June 2020, that the number of deaths will exceed 230,000, that's without any intervention. We will then look at a few cases of interventions to see what impact that has on death rates and shifting of the peak of the epidemic. The lockdowns in and of themselves do not flatten the curve significantly. They do reduce the peak infections. The major effect of lockdowns is that they delay the peak. They provide time shifting of the spread of the epidemic into a later time. This enables a country time to build new bed and critical care capacity and to prepare for the various interventions. Lockdowns, if applied inappropriately, may actually be quite harmful. And a key aspect of the base case, using some scenarios on lockdowns on the base case, is that the timing and duration of lockdown is critical. To achieve a significant lowering of deaths using lockdowns requires quite what I would call draconian lockdowns. That means a very, very little contact, and we'll explore that when we look at the simulator itself. So for the rest of the webinar, I'd like to just have a very brief look at the system dynamics model itself, which I covered in some detail in the CoSimPub webinar, so I won't spend too much of time on that now. We'll then look at the simulator itself, the user interface panel, explaining the different parts of the user interface, and then we'll explore a few simple policy options and scenarios and impacts. And in future webinars, we can use the model for a range of other scenarios and sensitivities. Finally, before I close, I'd like to explore how the model may be extended. This is what the actual simulation interface looks like, but we'll go to that in a moment after we first look at the underlying system dynamics model itself. So this is the high-level structure of the system dynamics model, and the way system dynamics works is it uses this iconography of stocks and flows. The rectangles represent stocks. Stocks are anything that can accumulate or decumulate. Flows are what changes the stocks. So these look what looks like pipes with faucets or taps are called flows, and it's actually the flows that changes the stocks. And it's in the flows where we actually model the various mathematical relationships between variables. This is where the scientific principles are modeled, as well as policy options are modeled in the flows. So if we just walk through the high-level structure of the model, we start off with a stock of healthy people, healthy population. If at least one person has been infected, and they come into contact with healthy people, then the epidemic can start, depending on the contact rates and the infectivities. So some of those patients will become some of the healthy people become asymptomatic, and after an incubation period, they become symptomatic, and we have a stock of symptomatic infected people. When they're in this stock, there are three broad possible pathways. One hopes that the majority of them would recover after a period, after recovery time, without needing any kind of hospitalization, but through home care and getting the necessary isolation and so forth. There will be a proportion of the population which I've referred to as vulnerable per thousand. So this would be a figure that we would put into the model itself. The vulnerable per thousand of population that would require hospitalization, and they would go through the hospitalizing flow and they'd end up in hospital, and after a period of time one hopes they would recover from hospital and they would also join the stock of recovered patients. Some of them regrettably would die, and part of what drives the death rate while in hospital is the quality of in-hospital care, and that's a non-linear relationship that drives that flow. What's not shown here is a little bit hidden. These extra circles represent an array structure. So this logic actually represents both those that require normal hospitalizing and those that require critical care or ICU capacity and that would require ventilators, etc. We have figures of vulnerable per thousand that require hospitalizing and vulnerable per thousand that would require critical care, and that would go down this flow. Then we have another flow that represents the ultra vulnerable in the population, the conditions in countries like South Africa, where we have many people with HIV/AIDS, tuberculosis, and other comorbidities, as well as quite significant class differences and access to health care. This represents the ultra vulnerable that require hospitalization or require critical care but do not have the opportunity for hospitalization or critical care, and that may be because they are so severely immunosuppressed that it's just not possible to even get them to a hospital, or it may be because they don't have opportunity because of economic reasons or distance reasons in terms of being in rural areas and so on. Once we've been through these three pathways, then we have the recovered patients who then return, and this piece of logic allows one to model either patients becoming immune or not immune, depending on what we learn from the science as we learn more about the epidemic itself. So that's the kind of high-level structure. What's actually driving the epidemic is from the healthy people, there's a fraction that is susceptible, and that susceptible population, when coming into contact with asymptomatic people or symptomatic people, there's a proportion depending on the infectivity and the number of contacts that would drive them becoming asymptomatic and then after a period of time becoming symptomatic. So that's the basic high-level structure that is based on a standard epidemiological model known as the SEIR model: susceptible, exposed, infected, and recovered. And this is it gives more granularity. It elaborates that basic SEIR model. If we just go to the right here, here we just see other pieces of logic. This is a piece of logic that works out the relationship between known cases and unknown cases. Here we model some bed capacity. This is just a piece of logic in scorekeeping variables to identify percentages. And here we model the lockdowns. There are two types of lockdowns. There's lockdown 1, lockdown 2, and the intensities, which then drive the actual contacts per symptomatic or asymptomatic. And by contacts, because COVID-19 spreads through aerosol and coming into contact with the virus through surfaces, it's not just contact between infected people and healthy people, it's also between healthy people and surfaces that infected people have been in contact with. So when we go to the user interface itself, you will notice that the number of contacts could be relatively high. It's not just contacts between infected and healthy people. We also model non-pharmaceutical interventions, which could represent things like levels of social distancing, personal protective equipment, and so on. And so the model has a bit of logic that drives that. And here, this calculates R0 and the effective R. And that's kind of the high-level structure of the model itself. If we now go back, this screen shows you the initial assumptions, the base case assumptions, and it's calibrated for South Africa. And I've started off with the number of known cases on the start day being 6,336, which was the situation about a week ago. By identifying all these initial assumptions, one may be able to critique this, and if the data is different for your context, or if there are differences between in terms of expert or medical opinion, this is where one would debate and mediate to try and identify and do some sensitivities on these variables. Here, this gives a sense of the lockdown intensity, the reductions, and essentially what the lockdowns do. They reduce the intensity in terms of higher intensity reduces the contacts between infected people and susceptible people. And you will notice that the lockdowns range from none through to low, medium, and high, and then draconian. And draconian is almost, it's just to show the effect of draconian measures, but it's almost unachievable practically. But that just gives a sense of what the impacts could be. The non-pharmaceutical interventions essentially translate to a reduction in infectivity, starting off at 15% reduction in infectivity, but there's a nonlinear decay in percentage reduction over 360 days, meaning that as time goes on, people start becoming more lax in the application of non-pharmaceutical interventions, and it starts decaying over a period of time. This is the link to be able to get to the simulator and the user interface.